Bon matin, tout le monde. Good morning, everyone. I've just learned that I'll have to be unpolite to you and maybe sometimes I on the side on my slide, so please forgive me. So I'm very happy to be with you here this morning, and I certainly thank Martin and the program committee for providing me with this opportunity to exchange with you this morning. First, I couldn't stand up this weekend when I think Rick asked who had attended 20 times NAPCRG. But what I can tell you, and thank you for, is I attended my first NAPCRG meeting in Quebec City in 1991, just out of residency in family medicine, presenting my residency research project. And the title was Patient Perception About Their Allergy to Penicillin. So I've attended multiple meetings, and I've also attended the NAPCRG PBRN in Bethesda. And certainly, as you were saying, Martin, you've been a family, a community of practice, and very inspiring, and I thank you all for this. So the next thing, I find it not necessarily very easy to follow up on Victor, who's a colleague and friend, and Joe Selby. But I got my lesson actually this weekend. This is why I had to redo my full slideshow. Is I heard that you want from your keynote or plenary speaker that they engage. So this is my engaging slide. That they bring something new. I hope I will. That they challenge us all. I think I'm not too bad at this. That they know a little bit about primary care research and primary care. So I've been a family physician since 1990, and a bit longer in primary care research because I was involved in the residency program in some research project. And that they have humor, I can laugh at myself, and that I'm funny. I will let you judge that. So my engaging slide. I would like, please, to ask Canadians who are still with us this morning to raise their hand. Okay, good. Now, no, leave it up. Yeah, thank you very much. Those among you who know the meaning of Canada, keep your hand up. Jillian, you're cheating, I told you last week. I caught you. We took the cab together. Okay, so Canada, this is a slide, is Jacques Cartier discovering the peninsula of Gaspésie at the mouth of the St. Lawrence River in 1534, meeting with the First Nation, and I'm going to emphasize this, be warmly welcomed by the First Nation. And this chief of the First Nation showed this village on the back and said to Jacques Cartier and his men, please welcome, come to Canada. Come to my village. Canada means village. And from my perspective, Canada is a small village. And we sometimes forget about this, but it has the mindset of a village. Welcoming, and certainly, whatever the perspective are from the outside, they stick together. So that's the meaning of Canada. So I've built my presentation, again, thinking about what I've heard since I've been here on Friday, because it was important for me to take from you what I've heard, but also bring in this new perspective and lesson I've learned myself. And what I decided to do was to actually build on the toolbox I gained when I first trained years ago, I'm not going to say exactly when, in architecture, because I trained first as an architect. And sometimes people think that I've moved to family medicine or in primary care research to study purely space, and that I live in a beautiful architect house. I don't. But this definitively it has provided me with a toolbox that has been extremely useful through my time in primary care research. So the nutshell or snapshot that I'm going to refer to are, none of us has 20/20 vision, and as you can see, I have glasses this morning, and I certainly need them. Our kitchen defines our cooking. So I've written a bit on the blog from the CMAG, and I thank actually the CMAG for this great opportunity to bring all the voices of primary care research together. We have a footing problems. I don't know for you, of those of you who build houses in cold country, it's a little bit sometimes more difficult than in warmer country. Elegant design means human messiness. Beware of the lure of standardization. And building cathedral takes time, it's time consuming and collaborative. So my first nutshell or snapshot is no one has 20/20 vision and no one has the same prescription. So my story goes like this. When I was finishing my architectural training, job market wasn't that good. Students decided to create a co-op to provide jobs and exposure to clients. So I will always remember my first and last client in architecture. So as a young, almost to finish architect, I met with this man who came for a consultation in architecture. And he was a medical specialist. He had worked very, very hard, many, many years in Quebec City in a lab. He was a biochemist or in the lab sector. And his dream and goal has always been to move to a cottage that he had bought years ago, a 2-story modest cottage in a rural site. So being a gentleman farmer, that was his goal and his dream. And he was consulting because he said, I have a problem. I have those 2 precious Persian carpets that are much too large to put on the floor because it's like maybe 20/20 and you know there are some walls. So he said, I cannot fit those carpets. So I need to enlarge my cottage. And I want to know how to do this, and it's nice and it doesn't cost that much, So as the discussion was going on, I said, who else is involved in the decision? And he said, well, in fact, my wife. So he was married, and his wife, they had no kids. And his wife had what I understood, had made a life of herself in the city. Quebec is 750,000 people. And she had made a life for herself. And when she was faced with this option to go to a cottage for retirement plans, she said, I go, and I only go if you can fit my Persian carpets in. So I suddenly realized and told him, well, sir, and respectfully, politely, I don't think we have only a space problem here. I think I understand that there may be some discussion that needs to happen between you and your wife, and maybe that should be a next step. So he got very agitated, excited, actually almost happy. He swore, he banged on the table, and he said, you're a woman and you understand that. So he said, could you come and tell my wife? Well, I said, I'll come back to my colleagues to discuss the case, team approach. I didn't feel fit for marital therapy out of School of Architecture. So the morning after, he left half satisfied, obviously, and I haven't him paid, actually. So the morning after, I walk into my class, and I asked this guy who's still an architect, very actually successful guy. And he said, that's so easy, France. He said, it won't cost that much. He said, you just push few inches one of the wall, exterior wall, just open it on the 2-story, and just hang the carpet. I was blown away because I found it was a very good idea that I had never thought of, really addressing space, money, efficiency, but perhaps not addressing other aspects of what I had heard from the men. But nonetheless, that really got me understanding that we have different lenses, vision, and that together we achieve more. And I, few months after, entered medicine. And my friend is still an architect. So that's the floor plan on 2-story. You push the wall a little bit, so you don't need to expand the full first floor or second floor, and you don't need to, it won't cost as much. So I was discussing with Rick that what it brought me to maybe get a sense of, and this is the way I've done it, and there's maybe multiple bias, I agree with you, Rick, is I thought, who's doing research in primary care? And I was a little bit cut in time, so what I did is I went to our CIHR website. I agree it's not the best way of doing this. And as I mentioned to Rick, I looked, there's a on this website, there is a public access to who's been funded since 2009, and I got out that there has been 17,000 grants awarded for a total of $4 billion. Then I entered primary and care. So again, please remember, I'm not a specialist of information here, and I didn't trunk and put stars and those sophisticated stuff. And it get about 800 grants, I think $50 million. And then I put primary care within bracket, stick together. And it could be anywhere in the abstract, anywhere in the what's been posted on CIHR. And it got to 400 grants, $73,000. And then I put family medicine. And then it got down to about 50 grants and a little bit less money. And then I put public engagement. And that, and again, it's not that public engagement with primary care necessarily, but it's by itself. And then I put patient engagement, got 14 grants. And I'm honored to say that 3 of those grantees are here with us in the room. Pierre Pluy, Mathieu Ménéard, and Marshall Godwin from Newfoundland. So really, we don't get that much there, but that was not my goal. I also wanted to compare with Larry Green, Ecology of Model of Care, that in fact, and I think you can see that out of the 200 or so people visiting a physician or medical doctor, there's about 100, it's primary care or family medicine. So I think it's around 30%. That if we had got 30% of $4 billion, we would have got $1 billion since 5 years. Imagine which type of cathedral we could build with this. But again, that was not what I was looking for. Then I took those 400 grants, and I ran one and one, trying to pull out the information about the discipline that was involved, because there's a line discipline. And there's a line, I think, department. And sometimes you know the person who's the PI. And again, please forgive me. Yes, I'm not going to submit this as a paper, so I know there are some noise. But it gives you a rough image that basically about 20% were coming or at the flag family medicine. And then it goes down very fast, health policy management, clinical epidemiology, it goes down. And then there are the other disciplines around or less than 1%, with anthropology, philosophy, respiratory medicine, philosophy, So rich lenses to study primary care. We're not alone, and when I'm talking about this, I'm saying from a Department of Family Medicine and being a family physician, and still, I would say and ask you and challenge you, what are your own prescriptions? And are there still any prescription missing? Food for thought. My second snapshot, aligned with what I've just introduced, is we have a footing problems. When you build, especially where I'm from in Canada, and you're right to mention this, Martin, in Quebec City last week we had at least a foot of snow, but yesterday there was about a foot of rain. so that's winter wonderland. And building in Quebec is quite complex because of the freezing, thaw, etc. And you have to have very good footing and foundation. So what I'm saying here is in primary care research, we have a footing problem. I hope that you've read this wonderful series of papers last year in the Lancet, January 8, just out of the Christmas season. Wonderful set of paper on the waste in research. And it's quite provocative because the authors are saying that 85% of research related to health is wasted. You may not agree about this. Each time I've discussed this with colleagues, they're shocked, they're in denial, and they say, no, it's not true. But nonetheless, that would mean that at CIHR, out of those 4 billion, if this was true, that's a lot of money that would have been wasted. But what's most interesting about this set of papers, because they're very good and thoughtful paper with some of the key leaders in thinking in the field, John Ioannidis, who's now in Stanford with his new center, Matrix, Paul Glasziou, Australia, Bond University, Sir Ian Chalmer, UK. And this is from Ian Chalmer paper, is what are the sources of waste? And the first sources of waste is we're not asking the right questions. That's the footing problem. Because after that, there's many other places where you're going to get wrong, and there's going to be more waste. But like when you're building a house in Quebec City, if you don't get your footing and your foundation right, you're going to have a lot of problem at the other levels. Okay? So this is where it should start. And then you have the importance of the research itself, sound research, valid research, reporting of research results. I'm not going to say anything, but yes, I'm having problems sometimes to get paper accepted. And definitively, when it's a negative research paper, or we think not that important, even harder to publish. So there's a whole pipeline of waste. But the first one is a footing problems. So I think we heard some very interesting material from Joe Selby. I think the PCRG has it very right, and that's a leader in the world, no doubt. But I think it's important to also to look at what's been done elsewhere. And in the UK in 2004, Sir Ian Chalmer put together the James Lane Alliance, which is a platform where clinicians and patients meet or actually interact, because it can be through electronic means, and they prioritize research questions, defining them and saying which one matters to them. So for Victor, I pulled out the one around diabetes type 1. And obviously the overarching question that they would like to be answered is, can I be cured of my diabetes? But nonetheless, they also have a set of other questions. They keep 10 usually, the top 10 priorities. So it's also a good source for you as researcher to see which type of question would be maybe fundable. And interestingly, there was multiple that I think we can well do in primary care, but even the last one, which deals with comparing, our teams of providers that are trained in patient-centered scale will lower blood glucose and get me better than those who are not, is certainly something that should be done in primary care. So this is, I think, a nice initiative. And what's now important to remember, because when I've discussed with some colleagues in research or even in other circles, they sometimes ask, what's the point to get patients in, and even clinicians and all the stakeholders, because it's complex. It's definitely complex, and it's true that we need to build a knowledge base for that. But nonetheless, here, what Ian Chalmer showed in his paper is, on your left, this is what patients and clinicians prioritize as research questions. In the middle, these are the research questions being answered by registered non-commercialized trial. And the right bar is the one of trials that are commercialized. And what you see, the green is like education, the way we do our services to patients, the soft part of medicine. And the green, as you will see, is very important from the stakeholder, patients and clinicians, and much less with the trialists coming from the commercial or the non-commercial sector. So basically the message is patient, stakeholder, clinician, change your research question. And next, as Joe Selby was mentioning this weekend, and this is a table from the Annals of Internal Medicine. Their paper just published this year on the impact of involving stakeholder patients in peer review process. It changed the scores. And then, as I was congratulating the team from Colorado this morning, Jack and the team accompanying Jack. It also changed, this is the work from Colorado, also recently published. It also changed the way people perceive they should be doing research. So the message is we have a footing problems with the lenses problem. And there may be a way to correct this. Stakeholder, patients, starting at the footing level to ask the right question, and then to peer review the project to be funded, and then to run them and disseminate them, etc. So can we solve the footing problems? And I think all you here have a very important role to play, either when you're doing your research, participating to research, or advocating for research, because definitively, I think many of you will do this very difficult job of advocating for us and for this to happen. Now, a line and another snapshot taken from architecture is our kitchen define our cooking. And that was what I use in the blog for the CMAG. So again, I've been amazed with the creativity of great architects in this world. And one that I think we should be proud of because he crossed both borders of our Canada and United States country is Frank Gehry. He's a born Canadian, but American, based in LA. And he's had a wonderful career. He's been almost recognized as one of the, maybe the best or one of the best. Anyhow, he started with his own kitchen. Probably, maybe it's his wife there in the kitchen. So he pushed the kitchen out of the house, actually. And he tried all sorts of angles and all sorts of funny materials that people would have not thought use. You know, he really experienced this in a comfortable, knowing well his environment. And you know, at first, I think it must have been shocking, perhaps to his wife, and also the neighborhood, obviously, but he got to be this great architect and building his PBRN now all across the world. So definitively, our kitchens are very important in terms of what's being cooked in them and what is defining ourselves. So my story that also was brought from being trained as an architect to now primary care research, I call it a room of our own, is as you were mentioning, Martin, I trained at the PhD level at the beginning of the 2000s, and because of lack of funding, had to do some collection of data myself. And I had very good support from 5 of our family teaching unit in Quebec City. They were wonderful people. Actually, my boss here is in the room, Guy Bellin, so I better say thank you to them because they work very hard. And when I was there as a research assistant to data collect, sometimes the clinicians wanted to work with us and with me and patient, but I was stuck in that type of waiting room, presenting the research project to patient and actually doing informed consent. So basically, people wanted to participate to our project, but there was no space. There was no telephone, there was no printer. We were really, pushing harder on the few resources that these clinics can depend on. So that's how I got to say we need our infrastructure. And I want to flag a paper that is an inspiration because it says in words better what I wanted to say. And Ro has attended this meeting. But an infrastructure for primary care research is basically the resources, system, and processes that are needed to do this job. And in architecture, we often say form follow function, and we have many functions in primary care research. One is running our project and data collecting and getting our research question at the level of the practice, doing knowledge synthesis, developing concept and models, some of us are very good at that, developing measurement, developing new analytical method, and I thank Jillian and her colleague for this wonderful workshop and step wedge design that you have run this weekend. We need to run descriptive study, which are not the same as intervention study. So we need our full infrastructure. And these will only then serve the purpose of the primary care research function. And where's our primary care PBRN? Because I'll just give you one snapshot on this, is where there is a PCRG grant in Canada. So yes, we're very happy about this. One of our colleagues, Holly Whitman, who's a human factor engineer and was recruited at Laval, got a PCRG grant last year, and what she's aiming at is finding a way to better engage stakeholders, patients in the development of decision aid. And we cover the east part of the province. And more specifically, we've developed our primary care PBRN on the idea of space. Now, each one of our 12 clinics where our residents are trained have 250 square feet, I need to change from meter to square feet, space dedicated to research with all the equipment, printer, phone, video conference. So when the clinics say they don't want to participate, it's not because we're lacking space. And if we go there with a team of a research assistant or graduate student or ourselves to do our research at the point of care, we have the equipment. The video conference, actually we share it with the clinician and they love it for other purpose. And we have our phone, we have our fax machine, we have everything. So it's small laboratory space identified as such on the door for research in the 12 unit. It's been funded by the Canada Foundation of Innovation and also partners such as a hospital in Quebec and also a primary care organization in Quebec. Our infrastructure for knowledge synthesis is not necessarily specific to primary care, but please forgive me for doing some publicity announcement, but I've been a Cochrane reviewer since 1999, so definitively Cochrane and the Cochrane community of practice has been for us very fruitful and useful for doing knowledge synthesis, not only Cochrane review, but also other type of synthesis. And the other part of the infrastructure I don't want to undermine is our own university, because for this whole set of other functions that we need to do, difficult analysis, measurement, etc., we need our university. And moreover, we need it, and I'll touch upon this at the end also, for capacity building. Because as I've discussed with some of you over the days, one of my reflections right now is where should we train primary care researcher, in which program. In our case, we need to have them train in epidemiology, community health, biostat, anthropology, etc. But definitively, maybe we're lacking something specific to family medicine, such as the program at McGill. So my question to you, are any functions missing? And do you think that our kitchens cover all these functions? Which brings me to another point, still aligned with the main message, is in architecture, we sometimes have the default or problem to try to match elegant design with human messiness, but when it gets too difficult, we just remove human messiness. Here an example. So while a trainee in architecture, thanks to some program of collaboration between Canada and US, I trained at least one semester in Louisiana at the University of Louisiana State in Lafayette for a full term in architecture. And we were lucky because we could go to New Orleans at Tulane to hear architects from the world presenting their work. And this is a presentation I attended from Aldo Rossi from Italy, a great architect. And I was amazed because through his presentation, he showed building over building, wonderful building, but none of them with people on the picture. And I walked to the micro at the end of his presentation, and I asked respectfully, "It's beautiful, sir, but where are the people?" I don't see any clotheslines when you show a building where people are supposed to live there. I didn't get an answer. But it gets to a point where, you know, it's almost caricatural, but I would understand here you would not see anyone because it's a cemetery. It's a cemetery by Aldo Rossi. So I would understand you have nobody there. But that's not most of our building. Most of our building have people living in them, working in them, thinking of them, in them, etc., caring, hospital. Rarely do you have only buildings for a cemetery. Now, what about us? Well, as Martin Fortin and others have told us, and Victor talked about this on Saturday, we've eliminated messiness in our guidelines. That's what happens. We've removed the patient, basically. And I've been polite here, because I would have shown a slide where, to show you about eliminating the messiness completely, I may have been able to show a slide where we know that with overdiagnosis and overtreatment, we're killing some patients. I didn't do that, I restrained. But definitively, we're not able to implement guidelines. So maybe it's because we've eliminated the messiness of human being. Which brings me to the lure of standardization, because I've already tapped on this a little bit, referring to guidelines. So out of the Second World War, now we're going to France, we're going around the world. There was a famous architect called Le Corbusier. And Le Corbusier had this wonderful idea of rebuilding some of Europe by having a standardized way of building apartment building. But what he started with was the modular, which is a man with specific size. And then you translate those size into the apartment. And that's not new, because Da Vinci had the Vitruve man, the guy like this in the picture. So he had this wonderful idea of huge apartment building, spanning across parks, green parks, and they would all be the same. Well, in some sense, it's been tried, and it was a social disaster. Because you cannot sometimes think that people will all be the same all the time, that they'll want to live exactly in the same building. And back to my own social disaster, we don't do that often, but I will do it. I will tell you of my mistake. I've published on this, but I will tell you about this. So in the 90s, I was a primary care provider dedicated to patients, wanted to do goods, and then wanted to bring the best care at the level of the patient. At the same time, I was entering into research and trained with a social scientist, and his expertise was changing behavior. So we had this adherence problem in the 90s. Not enough women were taking hormone replacement therapy for menopausal reasons, and not enough primary care were prescribing it. So we used the theory of planned behavior, which postulates that you can determine the behavioral intention of people if you know their attitude, perception of control, and social norm, because this is the most proximal determinant to behavior. And public health would then run a program based on a survey that would have been theory-based. This is what we did with about 400 women in Quebec and 400 physicians, please remember, in the mid-90s, not now. And I was struck by this because basically we were trying to understand the intention of women to uptake hormone and the intention of physicians to prescribe it. We were also trying to understand what were the key determinants so we could build a public health program and change their behavior. What struck me at the time is for women, if you look at the distribution of intention, it's almost normal, almost, because most of the women are telling you at 0, they don't know. +2 is yes, I'm going to do it for sure. No, I'm not going to do it for sure is -2. So they were uncertain, most of them. As for the physician, that was a U-shape. And in fact, we had to do a logistic regression because we kept being told by the biostatistician that you don't do a regular linear regression here. But nonetheless, it was amazing. Physicians said, I'm going to prescribe it, I'm not going to prescribe it, and almost no one were uncertain. So I thought, well, what happens when these women meet these doctors? As for women, the determinants that would have needed to be taken care at the public level program was women wanted us to tell them that if they take hormone, they won't lose their husband, they won't divorce, they will be a good wife, a good mother, and a good worker. That was it. Knowing about not fracturing or heart disease was not the main determinant. So from a public health perspective, if you wanted to be theory-based, you were not evidence-based. And as for the doctors, what were the key determinants? Not EBM, not knowing about the pros and cons of hormone. It was about moral norm and role belief. In a nutshell, it's morally wrong either to prescribe or not. And role belief, a doctor like me should be prescribing. So again, if we wanted to do a public health program, we would have kind of be theory-based using this, but not evidence-based because it's hard to find evidence that this has the outcome that they're expecting it to have. So this is when I moved to shared decision-making and decision aid and was lucky to meet with Annette O'Connor, who at the time was Canada Research Chair in decision support in patient and was developing decision aid. And please pay attention to this figure because she changed completely my paradigm. She was not focusing per se on changing behavior, but she had a model, not a theory, but a model, where the main blue dark dot is, are you comfortable with the decisions you've taken? And this is dependent on knowledge of options, pros and cons, what's important to you, the famous misdiagnosis of preferences, social support or undue pressure, and your belief of the effectiveness of the decision. And this tag into quality decision. So you're focusing on someone who's having a quality decision, one in which the choice match the best available evidence with what an informed patient valued the most. And I certainly got very, again, a ha-ha moment when in the around 2005 or 2007, I don't remember, when I visited Dartmouth for the first time and met with the people who were in charge of breast treatment program, and they were already using decision aid. And they were telling me that when women go through the process of deciding which type of treatment they're going to choose, if they have a sense that it's a mismatch with what they value the most, the team will sit with the woman again. So for example, a woman who says she values very much her body, her femininity, the way she looks, but by the end of the process says that she wants total mastectomy, they say, okay, we hear you well, but we want to sit with you and understand how come the choice to us appear maybe not matching what you say you value the most, and just let's rediscuss this together. And this is the type of decision-making that fits context of uncertainty. And another nice reading from 1985 is the probabilistic paradigm as the basic science of the practice of family medicine with Fane Bloom from UK, who basically called upon us to become decision brokers. 1985. And again, when people say, is uncertainty something that really we have frequently or very prevalent in our environment? Well, when you look at the BMG website of clinical evidence where they post, cystic review or knowledge synthesis of evidence, and you look at out of so many treatment options, those that they say it's white, so the population exposed to that treatment option will have benefit, doesn't seem to have any harm, and the black, it seems to have harm and no benefit. Most of the rest of the options are in the gray zone of decision making. So it seems quite prevalent. And even when you're in the white quadrant for some situation, As a primary care provider, you're meeting one individual, and as Victor has shown us with his wonderful decision aid, it's very difficult to explain this nature of the evidence drawn from a population level to the individual level and explain that, you know, out of 100 people, 10 will benefit. We don't know if it's you. We hope it's you. This is why I'm working hard as a primary care provider, but I cannot guarantee it. So we embarked in decision aid in 1995, translated in French the decision aid from Annette on hormone replacement therapy, trialed it with 100 women in Quebec City. And I won't show you the detail of this research because it's no value anymore. Why? Because there's 115 trials of decision aids in the latest 2014 Cystic Review of Stacy on decision aids. So please don't do another trial. I mean, you can, but please, and I think Dr. Selby said this nicely this weekend. So basically, we show everything else in Quebec, more knowledge. We had compared the decision aid with the guidelines of, and the pamphlet of the SOGC. So more knowledge, that the choice match their value, and actually reduce overuse. So in the case of HRT, it reduced the uptake of HRT. And this was my social disaster because in 2002, the WHI study came out, and I think some of you in the room remember what happened. It changed the evidence base of HRT, but this is our main newspaper in Canada, Global Mail. I'm not paid by them, no conflict of interest here. And that was the editorial, and it was pretty harsh on doctor. And it was a call for shared decision making. It was a call for decision aid. And it was a call for having learned from the HRT story, not like it's specific to HRT. Learn from it and expand it to all the other sector. So that's my social disaster, and from then on, obviously, I espouse Fane Bloom's concept of being a decision broker and embark more in a research program of shared decision making and decision aid. So the mission of the Canada Research Chair is really implementation of shared decision making in primary care. It's not good for branding or publicity because it's too long, but for me it conveys the three concepts I wanted. And I was non-negotiable on that because my university wanted to shrink down the title, and I said no. I'm in the implementation research. I'm a primary care researcher, and my research is about shared decision making. So I won my case. So our mission is providing health professionals and their patients with the necessary tools and skills to promote shared decision making throughout the health continuum, even though I'm in primary care and do a lot in primary care, because our patients move from primary care to other levels. And last, that thus, as I said, is a call upon us all, not only me, but all of us, to build a cathedral together. Because cathedrals needs a lot of time and a lot of us. And they last sometimes. And my take now, because I've heard you through all the previous days, is I've modified, my slides here, that I have a sense that it's at the minimum of 10 years to go from the bottom of an idea of research with your patient and clinician power practice-based research network. I'm sorry, I didn't get the name of the person who said this on a micro this weekend, but I loved it. For me, it was a moment. So thank you to you who have said it. And to go to doing a knowledge synthesis before you go and have an idea of a model or theory you're going to use, know which measurement you're going to use, and have a sense of the methods, etc., and doing a descriptive study before doing an intervention study. In our experience, we've done it with antibiotics for upper respiratory tract infection. We're doing it with interprofessional approach to shared decision making. We're doing it with prenatal screening for Down syndrome. It's about 10 years. But what we haven't done, and I'm calling upon you all because that's a major job, is we need to scale up. So I've had this function, but also we need to pay attention to capacity building because I've heard a lot of this in the previous days. Who will be the young people, the younger people that will be training through our function and that will take upon the challenges. So I'm happy to say and thankful that at least where I come from, the province of Quebec, thanks to the leadership of Jenny Agerty at McGill, we've combined the 4 PBRN of the 4 Department of Family Medicine and Emergency Medicine together. So it certainly gives a potential for the scaling up infrastructure that is needed. As well, I want to thank LG Fanyan for his vision, because a couple of years ago, he invited us to cross the border with him and bring PBRN from US and Canada together, with also this idea of providing more capacity for the scaling up of good idea in our own respective kitchen. So again, thank you very much. Last, sorry, and I didn't want to forget about another initiative in Canada and the province, which is a support unit led by a family doctor, Marie-Dominique Beaulieu. Thank you very much.